Good afternoon, everyone, and thank you for joining us for the Spotlight session, Approaches to Tele MOUD Services in the North Country. My name is Nancy Del Mastro. I'm the Telehealth Project Manager at Adirondack Health Institute, representing the North Country Telehealth Partnership, along with our partners at Fort Drum Regional Health Planning Organization. And this session is a collaboration with AHI's Rural Communities Opioid Response Program as well. And Sabrina's on the line representing our RCORP program. And we're really excited to hear from Alliance for Positive Health and the Matters Network today to talk about their experiences serving our communities in the rural North Country, and specifically chatting a bit about telehealth and virtual care options for MOUD services. So with that, we're going to get started. We are recording and we'll be circulating the slides later this week. So at this point, I'll turn it over to our partners at Alliance to begin the presentation.
Thank you for having us. My name is Carrie Coyer. I am one of the program managers at the Alliance for Harm Reduction. I'm here today with our provider, Brett Palmer. He is a PA here. And Snide, who is our linkage navigator coordinator. We have long titles here. We want to give a little information about our program that has been open since 2019. Next slide. Just a quick outline, a quick history of the Drug User Health Hub or Suboxone Bridge Clinic at the Alliance. What is our clinic? How to refer to our clinic? What happens in a provider appointment after the initial visit and follow-up, and contact information. Next. So just some information going way back. In 2018, one of our staff members called every place in Plattsburgh, all the primary care providers. One person that she spoke to knew what Suboxone was, but no office in Plattsburgh actually prescribed Suboxone, which we have about 3 different offices now prescribing, but they're a lot more open to it now. They do work with us more, maybe 3 or 4, I'd have to say. The Alliance hosted the first waiver training for providers in the area a few years ago, and we did a couple of little stories. We received some pushback from a local pharmacist who expressed little concern. They thought that we were supposed to be weaning people off Suboxone. So with some education, discussion, that's not the case anymore. He understood that, what Suboxone, how it was going to work, and we have a better relationship with that pharmacist now. And why do we do this? A really good story is before receiving the hub funds. So I started in May of 2019, but this has been a project that had been started for years prior. They had the people before me had worked many years trying to get this up and running. So when I came on, the hard work really had been done, laying the groundwork. I just had to run with it, and it's been great. But so before the funds actually were here, and before we could get the hub going, we had 2 different syringe exchange program clients that were pregnant, and they needed help to get buprenorphine. We got them buprenorphine. We got them providers, OBGYNs, and I'm so happy to say that they're doing really well. Their babies were healthy. And that's really just pure motivation for us to just continue to do what we do today. It's a learning curve. We're always doing something, trying to do something different every day. We're always learning what from different things that are out there, but we're working on it. Next. Okay. Here at the Alliance, we were able to utilize our drug user hub for all different counties in northern New York. So we go as far as Albany. We've actually gone to New York City. So we have worked with docs, and the docs community has contacted us, and we have helped people that were getting out of docs, and they were moving to the city, and they weren't in a long-term provider, so we helped them. So there really is no absolute no. It's every situation is different. We don't like to say no to people. Our provider again is Brett Palmer. He is a physician's assistant. Our clinic does Suboxone. We will do Subutex when they have usually when it's documented, and we can see that they have had issues if they've had it. Brett's really good about that. We like to work with providers in our community. We love to work with the OASIS programs. We get a lot of referrals from our OASIS program facilities in our areas, and our online providers also, like Reach, Ophelia. And we can link clients to harm reduction services. So we do wraparound care. It's not just about the Suboxone. Do they need a dentist? Do they need primary care? How's their mental health? Because we all know that it's hand in hand. We are all about the person. Do they need food? Do we need to go upstairs and get them food? It's all about the person. It's client-centered care. And when they leave us, we want them to know that we actually care, and they're very, very cared for here, and they become our friends. We want them to know that they're cared for here. Next.
Bianca Snide here. I'm going to take over the slides from here. So some more about our clinic. We're a low threshold buprenorphine program. So low threshold in the sense that, we don't require our folks to go to individual counseling sessions. We don't hold group sessions here. We just ask that they attend their appointments with the provider and then work with me. So in the interim on any linkage to care that they might need. So what happens in our clinic, we offer appointments on Mondays and Wednesdays every week. We have 2 days a week that are devoted strictly to appointments for our Suboxone clinic. Sometimes if it's off hours and we have an individual that calls and it's an emergent situation, Brett can do off hours appointments, sometimes in the evening or early mornings, depending on what's going on. Sometimes he's even done one on a weekend, in a spur of the moment type of situation. So really just depending on what the situation is, what is the client able to do at that time. We do in-person and telehealth. Obviously, that's why we're here, is to talk about telehealth. So we can offer telehealth to people that are far away, right? So if we service clients all the way down to Albany, where we're several hours away from, they can't get to our clinic, we're able to do telehealth appointments. Brett will speak a little bit more on that. If for some reason he's unavailable, we cannot do an in-office appointment, can't do a telehealth appointment. We defer to the virtual emergency departments that are available through the Matters program, which I'm sure we'll discuss a little bit later, but that is also a resource that we use if our provider is unavailable and not able to do something in that moment. Next slide, please. So how do we refer to our health hub? So there's a couple different ways that it can be done. One of the most simple ways is to just make that connection with myself or with Carrie, and we'll get the individual registered and into our system. But if you want a more formal process, there is an actual referral form which we can distribute, hand out to anybody to fill out. And it can be sent back to an email address that we have devoted just to the hub. So hub@alliancefph.org. That will go to myself and Carrie or anybody else that's on the hub staff, just to be able to triage that referral. If for some reason a referral form, can't be filled out, you're out in the field somewhere, it's a really spur of the moment situation, the phone number down at the bottom, that's our hub phone number. So you can just call that number, but the individual, they can call the number, you can call the number as a service provider. It's really the comfortability of the client, and then we'll be able to take the information, get the client registered, and get them into our system. So really, there's no criteria or requirements to be able to be a part of our program. Anybody that is able to benefit from our service can be a part of our program. It's not like you have to meet, criteria 1, 2, or 3 to be able to come into our program. As so long as you're looking for any type of linkage to care, we'll be able to help you out with that. And then the referral form is really tiny on this little slide here. I understand that. So it does ask for just basic demographic data, the person's name, address, phone number. We do ask for an email address so that if the person has an email, they have access to filling out the paperwork online, which I'll go into that a little bit further on the next slide. But and then also most recent lab results. So have they been tested recently for hepatitis C, HIV? What are their results? And then there's just some additional spots for services that they may be requesting for you to be able to check off. So that's how you refer to our clinic. But really the thing to remember is, even if you can't fill this out and do a formal referral, contact this number, contact myself or Carrie, and we'll be able to help the individual. Next slide, please. So new patient paperwork. Excuse me. So this is what I mentioned, why we would collect an email address. So we have the capability to be able to email the client the paperwork. They can electronically sign the paperwork. So what's included is the consent for services. There's going to be a HCSNI release in there, release of information for their chosen pharmacy, Medicaid release of information if they do have Medicaid, and any other place that they may need a release of information for. We can email that out to them, have it all pre-filled out, and then they just have to electronically sign. We've tried to make this process really flawless, seamless, so that it's a very easy thing to be able to do. Sometimes people don't always have access to email. So what we do is we just have the individual come into the office for the first time appointment, and they're able to sign that paperwork in person before they talk to our provider that way. Sometimes I know technology is not always the most cooperative, so there's always that option to come in and sign them in person. If it's somebody that's also farther away in another county where we happen to have other offices, we can coordinate with other staff at our other offices to be able to get the person to sign the release, in person if it's easier to meet up with them that way. So there's a couple of different ways that the paperwork can be done, but there's just a little packet of paperwork that they fill out for intake, which is standard to most offices. Next slide, please. So uninsured clients, what's really cool about our program too is we do not require health insurance to be able to be seen at our program. Most often people are very surprised by this. Like they'll go to give me their insurance card and I said, we don't actually need that. We do have the capability to bill for Medicaid. So if they do have Medicaid, that is something that we will utilize. We'll have them sign a release for, and we're able to bill for services. But if someone is uninsured, if someone has private insurance, there's no fee or there's no cost to our actual appointment. So they're able to just come in, receive the service by our provider, and then the only time they would need to use any insurance or monetary exchange would be to pick up their medication at the pharmacy. And if for some reason they do not have insurance, they don't have the means to be able to pick up their prescription at the pharmacy, we work with the BUPAP program. So that's able to fill out an application for somebody to get what looks like an insurance card to be able to bring to the pharmacy, and it will cover the cost of their Suboxone or their Subutex, any buprenorphine products for a year, and then they'll be able to re-sign up for that program, and if they're still eligible the following year, it will still cover. So it's just if they don't have the means to pay for it, we're able to help them with that too. So really, it's again trying to make it a seamless process to get them their medication. They don't have to pay for the appointment. They don't have to necessarily pay for the medication. So this way, there's less barriers in the way for the client. So it's just a really great thing to be able to offer that sometimes is a barrier to a lot of people. So next slide, please.
All right, so I'll take over from here. So my name is Brett. I'm the physician assistant here at our program. I've been here a little over 2 years, and I'm also involved in, I work at the local methadone program here in Plattsburgh, New York, Conifer Park as well, and then involved in some other programs that provide substance use treatment as well. So when a patient comes to see me, they've usually done a brief intake, at least with Bianca or Carrie. Um, those initial appointments, I'd say probably half and half. Some are in the clinic, some are over the phone, like Bianca said. We do have the flexibility of, if a patient is new and they don't have a current prescription or needing one, and we can't link them with one of our other partners to get started, I usually make it as best an effort I can to see them with a phone appointment. Sometimes it's just more brief, so we get the basics done, and then when we see them next, I can kind of go through more. But that initial visit's similar to like any intake, history, or physical, reviewing basics like medical history, mental health history, their medications. What I always try and focus on what kind of care they're already involved in. Many patients, don't have a primary, don't have mental health, and so those are conversations we get going. The other big things I focus on is what has been going on lately for them. What are they using for substances? A lot of patients are already taking buprenorphine off the street. They're very familiar with it, or they've been on a prescription before and then lost insurance, or something happened with that provider or clinic and they were kicked out and they've just been buying it off the street since then. So we talk about the medication. For anybody not familiar with buprenorphine, I try to review it and review the properties of it. There's a lot of patients who don't know necessarily all the properties of buprenorphine, how to take it the best way or get the best absorption. So I try to review that as well, and then just what they have access to. We make sure every patient has Narcan, test strips, fentanyl and xylazine test strips. We review our services here. That initial visit is always really important, I find, for just setting the tone, letting them know, hey, we are a low threshold program, low barrier. Your treatment is safe here. As long as you attend your appointments, you'll get access to the medication. I try to make that really clear from the start so that they feel a bit more comfortable. And I always make clear too that if there's anything they're not comfortable sharing with me, they don't have to. I don't want to make them feel uncomfortable, and I want them to be able to tell me what's going on, and so that way we can come up with a plan to help them with it. And then follow-up appointments, usually I see patients at least every 2 weeks, sometimes earlier if we need to. If we're just starting someone on the medication, I'll see them within a few days, or have Bianca or Carrie check in with them and say, hey, can you just find out how they're doing? I can make a dose adjustment if I need to without necessarily having to see them. And otherwise, there are some patients too, so we are a bridge program primarily. We're usually seeing patients until we can get them set up somewhere else, but that's not always a very quick process. So we'll have patients who are with us for several months or more, and if they're doing well, I will sometimes see patients monthly. But at those follow-up appointments, we're doing dose adjustments if we need to. For newer patients, we're reviewing if they're still using substances. And what they're using, why it's happening. We don't do, like Bianca said, we don't require counseling or groups or have many stipulations here, but we still try to talk to patients and provide help to them, for what's going on, like what's causing this, why are you still, if they're still not having good housing options, like we help them get better housing. If it's still mental health, we try to link them with that. And we do whatever we can to help them. I also try to at some point talk to patients about, as we're going, about the reality of returning to substance use, or sometimes they call it relapse. I think relapse is one of those terms we try to avoid now. But for many patients new to starting treatment, they might do well for a few weeks or a few months and then return to using substances, and it can be very discouraging for them. And so I try to have that conversation early on, like, hey, those things do happen. It's okay. This is a hard thing you're going through. This is a hard thing to do. Just to, again, kind of establish that rapport with them and let them know they can talk to us about what's going on. They don't need to hide if they are still using substances. I review any medication changes, health changes they've had, always kind of reviewing our plan for where they're going to go next for MAT, talk about options. I think that's, so those are all sorts of conversations happening at the follow-up visits. Next slide. And again, so this is like after an initial visit and any visit, really kind of the in-betweens. We already talked about how often patients are seen. Bianca and Carrie are great about checking in with patients if there's ongoing issues that they're working on as well. We can link them with other services if we need to. You know, again, a lot of services are limited. I'm sure many here know housing is a hard thing for everybody. Getting patients into primary care. I mean, most of the major offices here, you call and they're booking into 2025 for a new patient visit. Even with the elimination of the X waiver for prescribing Suboxone, I don't think we even really noticed any difference after that went away in terms of local offices prescribing more. The offices that were already doing it still are, but the ones that weren't still aren't. So, you know, we are limited in where we can refer people to. The telehealth providers, such as Reach Project out of Ithaca, Ophelia.com, and then there's been some others too, are common ones we refer to. We don't have a hard, like I said, we're a bridge program, but we don't really have a hard cutoff for patients for how long they can stay with us. And I make that clear with them. I say, hey, as long as you're attending your appointments, we'll continue to manage your MAT and we'll continue to help you. You know, we usually encourage them, hey, have you called Reach Project yet? Hey, have you called to try and get a new primary care, get in with that primary care office? Or, hey, do you want to come in and we'll call with you? You know, we do things like that to try to help them, but we don't ever force people out. Really, there's not many situations that would ever have someone removed from our treatment here unless it, you know, there was issues with staff or things like that. But no matter how bad their use is or how bad things are for them, we want them to know that they can still come here for help. Let's see, we kind of talked about all that. So next slide. The other, you know, the main point of this presentation, so talking about telehealth care, so telehealth MAT, it's been a big change over the last few years. So I really got involved with substance use treatment right as COVID started. It was actually, I think, March of 2020 is when I started the methadone program. And before that, things were already changing in terms of MAT. You know, I think harm reduction was becoming bigger. We were understanding harm reduction more. I think there are a lot of places that call themselves doing harm reduction, which they are, but don't, you know, I think it could even go further for a lot of things. Treatment was becoming a little bit more lenient, lower threshold, lower barriers. We recognize that, hey, are we doing this as best we can? And then COVID happened and really accelerated the need for us to adapt. The common phrases like meet the patient where they're at. You know, if a patient's not in treatment, then nothing good is happening. So, you know, even if you can engage patients in any kind of treatment, it's still better than nothing. So a lot of rules changed. Obviously, once COVID happened, telehealth became a thing, right? We had to do phone appointments. We had to still see patients somehow. I think that made a lot of people uneasy. Well, hey, we can't get urine screens. We can't watch them. How do we know if they're not doing the wrong things? So even though rules changed quickly, a lot of practices, I think, still struggled with those changes. You know, we can't change that fast. We're never good at big changes in any aspect in terms of healthcare. And working at a methadone program too, there was also a lot more restrictions around methadone. Methadone the person still had to be seen in person for that first visit. Suboxone was more lenient. You could start doing phone appointments to start patients. But then, you know, we tried to still see them in person sometimes. But I did also realize, you know, as we started doing more phone appointments, and I think there was kind of this common notion like, oh, if someone's avoiding their appointments in the clinic, they're up to no good or not doing, you know, what they should be. But really, a lot of patients just struggle with going to any kind of appointment. There's a lot of anxiety around that. A lot of patients don't have good transportation or access to it or childcare. There's so many barriers for people to get to appointments. And before we had telehealth, a lot of times it'd be, hey, you missed too many appointments, you can't be seen here. So having telehealth has created a lot of options, especially in substance use treatment. The rules, you know, have changed a lot. The COVID rules ended, and then the DEA had proposed new rules to kind of return to more in-person appointments. As far as I know, I may not be the most up to date, but I think that all got postponed. Obviously, there was a lot of pushback. So I think there are temporary rules that have extended the COVID rules where buprenorphine can be prescribed over the phone or via telehealth and not need an in-person visit. How I expect that will probably stay, but I think it's still considered a temporary ruling. So we've already talked about a lot of the positives. I mean, I think the biggest thing, as we'll see throughout this presentation day and have experienced, is increased access to care. I mean, there's so many people seeking treatment because they are able to do it over the phone. Here at Alliance, we still combine most of our visits, like in person and over the telehealth. We're doing mostly phone appointments. We have done some Zoom or video visits. I know some programs try to do Zoom or video visits more often. Patient comfort's a big thing. I mean, a lot of patients are just more comfortable talking over the phone. They get very nervous going into a clinic. You know, there is and has been a lot of stigma around MAT, and it really still exists in not just, you know, I think a common place is emergency departments, which I think it's gotten better from what I've heard and seen. But unfortunately, you know, I've seen the stigma exist even in places where they use MAT and treat with MAT. I think there's just a lot of changes going on, still a lot of progress to be made, but there has been a lot of progress that we have made too. And the other big thing for me, as we've talked, is flexibility of appointments. You know, if a patient misses what was supposed to be an in-person visit, I can call them up, say, hey, you know, you missed your appointment. Everything okay? Oh yeah, I didn't have a ride, or I couldn't get there, or I forgot, you know. But whatever it may be, I can say, hey, do you have a little bit of time to talk? We can just do it right now, and I can catch up, make sure everything's okay. You know, that leads to some of the negatives. So you might say that, okay, you can't monitor patients as closely, which I agree is true in some sense, but the only way I really agree with that is you do get a good sense of how someone is doing based on how they appear. You know, you can usually tell if someone's doing well or not based on how they look. I think a lot of people focus on the fact that you can't do regular urine drug testing for patients when you're doing primarily telehealth, which may be true, but I honestly, in the time I've been prescribing Suboxone and methadone, have never found urine drug screens to be that helpful. Usually if a patient's not doing well and they want to do better, they'll tell you, you know before you even see the results of the urine drug screen. Or if a patient's not doing well and they want to hide it, they don't usually admit to whatever is on the urine drug screen, or they find other ways to hide it. And I don't push that. You know, if a patient's not ready to talk about what's going on, that's okay. You know, if this is, again, a hard process for a lot of them. So overall, you know, we don't really do routine urine drug testing here at Alliance for Positive Health. We do it at other places I work. But I don't find that it makes that big of a difference in terms of outcomes of patients. You know, someone's not going to do better until they want to. Forcing their hand or kind of like forcing those conversations never really leads to like good conversation or good progress. You know, and going hand in hand with that patient accountability, I think phone appointments, having the option of a phone appointment allows them to miss their appointments a little bit easier. Not, you know, oh, I missed my appointment, but that's okay. They can call me or I'll call them, which is good. But I think, you know, for terms of scheduling, it's hard sometimes when you have a lot of no-shows. I find that my schedules at all the places I work never really go as scheduled, but we get it done and it ends up working out okay. Not all patients have access to a stable phone, so that can be a barrier, which again, most of our patients we can see in the clinic if that's easier for them, or we find ways to get them a phone if we can. And then also, as Bianca mentioned, we try to get email so we can get a lot of paperwork done, but sometimes patients don't have access to email or aren't tech savvy able to do that as well. So far, I think we've done a pretty good job of working through that and getting the necessary stuff done so that we can see them and treat them. But that is one thing you got to think about when you're not having patients come into an actual building to sign stuff and review stuff. Let's see, and I think that kind of about wraps up most of my stuff. We can go to the next slide. Yeah, and there's all of our information.
Thank you so much to Carrie, Brett, and Bianca. Right now we're going to switch gears and hear about matters, and Phil will be taking over. And again, for our participants, please place any questions, comments in the chat, and once Phil is done with his slides, we'll get right into Q&A. Thanks.
Thanks, Nancy. And yeah, thanks for everybody for having us here today. There's a couple of members of the Matters team on the call with us today, both Marty and Donna and myself. But I just wanted to start off by saying thanks to the team at Alliance for Positive Health too, who are one of our main partners and as the drug user health hub in the region have been one of the main kind of pillars of the Matters and the success of the Matters platform over the last couple of years. So I just wanted to start off by saying thank you to the team for their kind of long-lasting support. So just to start off, really, I'll just give you a brief history for those who are on the call who are not particularly familiar with Matters. But Matters started approximately about 2016 in an emergency room setting. Dr. Josh Lynch, who is our CMO and founder, really seen the same situation that a lot of emergency room physicians were seeing and that Brett alluded to. You were fine on that other slide. That was totally fine. So what Brett alluded to was people using the emergency room on a recurring basis, you know, and addiction is not a one-time thing for a lot of people. They may come through on a kind of repeated basis. So Dr. Lynch was seeing a lot of individuals coming through an emergency room on a recurring basis and decided to look into seeing what the issues would be, what the person was facing kind of after that, getting connected to long-term care. And he found, and again, as a lot of people have alluded to on the call, stigma at the time was a big barrier to treatment, whether that was getting access, whether that was feeling comfortable seeking care, whether that was actually getting access to care itself. So whether that was long wait lists to get into a clinic that was existing, a small number of clinics that were actually providing care, or whether that was long wait times to get connected, whether that was staying on hold, finding the right number that was still existing. There were also some other barriers like finance and transport. And I think specifically speaking to the region that we're alluding to today, both of those issues have been mentioned already, especially like the distance to have to be traveled between clinics and the lack of providers that are available. I know the X waiver was a limit to the providers that were offering buprenorphine prior to that being retracted. But even since that, one thing that we found across the state, and we actually have it built into our platform, those who were providing already have continued to provide, and there hasn't been as big of an uptake on providers offering those services. And I think that may just come down to education and comfortability as well with the actual medication itself. But also, you know, that everlasting kind of stigma and treating that patient population. Next slide. So looking at these kind of overarching kind of barriers, Dr. Lynch really kind of reached out to a number of providers here. Matters kind of started here in the Buffalo area. He reached out to a number of local treatment providers and asked if he could send hospital discharges directly to them for direct care, specifically for opiate use disorder and specifically to get access to buprenorphine. So that's where Matters was born. So what we do here at Matters is that we have a rapid referral platform that's used to effectively link people with opiate use disorder to MAT programs 24/7, 365. We try and do that through multiple resources that you can see on the right-hand side of the slide. So we have the referral platform itself, giving individuals access to over 2,500 MAT appointment available slots all over the state. And a big portion of that are telemedicine. We offer a medication voucher that can cover up to 14 days of any oral buprenorphine script to cover those who have financial issues or a break in their insurance coverage. We offer transportation voucher that can get you to and from that first clinic appointment. And for those who are not in a medical setting or those emergency settings that, you know, can't get hold of Brett or anybody at the AHI in that emergency situation, whether that's weekend or evenings, they can get direct access to a telemedicine provider for an evaluation. Once they've done the evaluation and the person is appropriate, they could provide a bridge script and then a referral to long-term care as well. And we also offer our extensive harm reduction services that many of you are familiar with. There's one more slide, there's one more kind of circle that we actually hope to add to this now that we've just recently added, which is a 24-hour follow-up call by one of our support services staff. We've started to hire an additional member of, we've started to extend the outreach team. We've hired one a support services person who will be operating 24-hour follow-up calls with the person to make sure that all of these services have been connected and that the person has had access to all of these additional services. And then also to ask any follow-up questions about what other services that person might need connection to, and then pointing them in the right direction for those resources. Next slide. So how Matters works, it's really simple. Matters is a bridge from any of those community organizations, telemedicine providers, law enforcement, emergency room settings. That's a bridge that you can use, or a tool that any of the staff at those agencies can use to get connected to those treatment organizations that may not be physically in their area, or they may not be able to get access to an open available slot. So by using the Matters platform, you can get access for free to over 2,500 MAT available slots across the state. Next slide. So some of the goals that we have during each encounter is to connect any individual with the appropriate treatment within their own community within 72 hours of presenting wherever they are. We want to minimize the window of time from when the individual is encountered to when they're cared for. And as mentioned, for those who are not in a medical setting, we want to be able to get them connected to a telemedicine provider for an evaluation to medication if appropriate. Next slide. We do ask that all of our partners align with our core values, and I've just highlighted a couple of those core values right now. Not placing counseling appointments, group sessions, and other requirements ahead of being seen and evaluated by a provider. That our individuals are not automatically disqualified for continuing in polysubstance use or continuing with their addictive behaviors. And we also ask that our partners see all of the Matters referrals on an unbiased basis, regardless of insurance status. So at least that they can be seen for their evaluation, connected to an insurance navigator, and then they can apply for a back pay on their Medicaid if necessary. But we do ask that the person not be disqualified based on their insurance needs. Next slide. This is a map. It's an interactive map that's available on our website, mattersnetwork.org. But this map just shows you the extent of coverage that we do have all across the state of New York. Obviously, Western New York and New York City, the Hudson Valley area, we have kind of extensive coverage. We can also see in the North Country some gaps in that map, and that's obviously regionally appropriate. I can go on to the next slide there. We can actually show a little more detail of the North Country and some of the progress that we've made over the last kind of number of months or years. So you can see in the first map, this is the North Country specific partner map. You can't see everything because a lot of those partners are kind of overlapped in those areas. Like Watertown, for example, there's a number of treatment providers there that you can specifically see. But the map on the bottom does highlight something that I think we're all here really to discuss, which is the advantages of telemedicine. Based on that map, just geographically, the distance between each one of those treatment providers, if somebody is based not near any of those, it really increases a barrier to care. So some of the issues that are raised by that, obviously, the limited amount of treatment providers that geographically you may see elsewhere on the map may have more options. There's large distances to be traveled between each one of those partners. Whether there's limited transportation options, even if there are, Matters does offer a transportation option, but whether those transportation available partners are there in that region is also a real barrier. So whether somebody has a disability or mobility issues, that even if you do have a treatment partner that's available, whether you have these issues that you can't physically get to those appointments, and then a correction setting. We also partner a lot with the Department of Corrections and a lot of county level corrections facilities to provide a safety net when somebody is re-entering from periods of incarceration. That period, as we all know, anybody who works in the MAT or the MOUD space, corrections facilities are transitioning very quickly now at the moment. A year ago, 2 years ago, the MOUD requirements for corrections facilities was a lot lower than it is right now. Recent legislation has really required a lot of those corrections facilities to continue MOUD care or to start MOUD care where appropriate. But then on the transition, when somebody is re-entering, there's a lot of barriers to that too. So Matters really offers a lot of safety net throughout that process. The telemedicine evaluation and the medication voucher really covers a high risk period of time for individuals. If their Medicaid has been paused because they've been incarcerated, it may not kick in straight away, so they have that gap in coverage. So these are some of the barriers, again, that telemedicine really goes a long way to kind of address, specifically here in the North Country, but all over the state as well. Next slide. So why use telemedicine? Again, getting access to that rapid evaluation if you're not in a medical setting. So if you're one of our traditional partners, but you're a community partner, if you're on an outreach team, you come across somebody using the telemedicine in that facility or in that environment is perfect to get access to that medication. And if that individual wants long-term care, all of our Matters providers are also linked or are trained on fully linking them using the Matters referral network. That will also get them access to the medication voucher, any of those harm reduction supplies if necessary, and also the transportation voucher. And since this slide has been made, we'll also, be initiating those 24-hour follow-up calls where appropriate. Next slide. So just to speak about telemedicine in general, Brett, I know kind of mentioned the changes in kind of legislation over the last number of years, and especially since COVID. Those changes in legislation based in COVID have really opened up the opportunities for telemedicine providers to continue people's care. And a lot of research has been done in those last number of years really to try and increase or continue the extended openness of the legislation, or to at least write new legislation to cover telemedicine providers for OUD. So a lot of the research that has been done, it's still a lot of it has still yet to be published because it's in the early stages. They're still going through a lot of that, but a lot of the numbers that have been kind of published so far are all pointing in the positive direction as far as the success for rural telemedicine, reduction in kind of recidivism rates for people in incarceration who've been able to continue MOUD care based on a telemedicine provider, the success rates of individuals who have been continued on care and who have not just been connected to care, but have actually continued over a 30, 60, and 90-day period. So there's a lot of research being done, and a lot of the research is looking in a more positive direction as well. Next slide. So through Matters itself, we're just speaking about our medication options that we do have. We have a number of tiers that we do have through Matters. And again, Matters was created to cover gaps in service. And as Matters has grown and evolved, as we've listened to our partners on the ground, as we've gotten feedback from those who have used Matters, there's certain things that have come to light that we have, again, tried to address. So the number of tiers that we do have, we don't kind of specify what's a more or less advantageous or a better option for people. We just try and give people as many options as possible based on their circumstances. So if we just follow this slide right through, anybody who can come through the individual when they're ready for care, they say to that emergency room, to that outreach provider, or the person in the corrections facility that they're ready for long-term care. Once the person is registered with Matters, there's a number of different options for them. So if they're in a medical setting, like an emergency room or a primary care setting, or if they're in an inpatient facility and already on MOUD, they can just follow the traditional Matters referral to get linked to a long-term care provider, and the physician that they're linked with can continue there or write a bridge script for them to get through. So that gray line on the left-hand side, they can simply come right through. On the other hand, though, if they're in a non-medical setting, they can opt for our tier 1 option. So if you're on a street outreach team, you're doing a harm reduction training, and somebody says, I would like to get connected for MOUD care. If you're registered with the Matters network, you can go online and make a referral. But like myself, I'm not a PA, I'm not a doctor. I can't write that script if I'm on the street, if I'm doing some street outreach. But what I can do is get them connected to our telemedicine provider who can do both of those things. They can do an evaluation as quickly as within the next hour once you register for that. And we can walk through how simple that registration process is. So again, based on their setting, we have their first tier 1 medication option. Going down from there, once that option has been made and the person has received the bridge script, then they'll have 2 options as well. They can go directly to a brick and mortar long-term care provider in their region. If they have one themselves, if they have one they prefer, they would like to go to, they could select that as long as they partnered with Matters. But if they don't, again, if they're living in the North Country and their closest treatment provider is a long way away, or they have those mobility issues that they can't physically get to those, we do have our tier 2 option, which would be, again, as Brett mentioned, those 2 fully online MAT providers. So Reach Medical and Ithaca is one of our main partners, and Ophelia, who are based in New York City, they will initiate from the beginning. They can initiate your MAT all the way through to long-term care as well. So that's our tier 2 option. And a number of our referrals, a high number of our referrals are based through those 2 treatment partners. Excuse me. Once we go on from there, if that person decides to go to a brick and mortar, whether again that's from that medical setting or through the non-medical setting, if they've chosen to visit a traditional model, we then have the option of going physically in person to your first or second appointment. We then have a long, extensive list of partners who will offer telemedicine on an ongoing basis, but you will have to physically go there to your first appointment to be to go through the intake procedure, be seen by them, and then you can have that discussion with your medical provider to see if telemedicine is appropriate moving forward. So we do have those 3 different options throughout the Matters platform. Next slide. So this is just a walkthrough. I actually have the card here as well. This is a telemedicine leave behind card that we've produced recently. And those steps that are available on the card there, so to navigate, prepare, and connect, it's a really simple process to get connected, to initiate the process yourself, to get connected to one of our telemedicine providers. So again, let's speak about a street outreach situation, or a naloxone leave behind program, which I know some of our partners on the call actually are involved in. So we're asking a lot of our partners to leave these cards in with those harm reduction kits or those naloxone leave behind kits, especially our EMS partners. Our EMS partners have, we've gotten a lot of feedback from our EMS partners that they may come across individuals who have overdosed, who may not want to be transported to a hospital, and they feel when that person declines and then leaves, that they don't have any real hope of connecting them to care. So this card empowers that individual with a direct line themselves. When they get home, they feel safe and they're a little less heightened. They can actually get direct access to a telemedicine provider for that evaluation and a link to long-term care. Next slide. So I'll very quickly go through this kind of process. This is actually what that card shows. I won't delay too long on these cards, but this is just a kind of walkthrough. You can just go to our website, mattersnetwork.org, click on treatment, click on virtual care. Next slide. Then you'll have 2 options. You'll have 3 if you're based here in Western New York. We do have a 24-hour hotline, but in the remainder of the state, you'll have 2 options to click on. So either ECMC or Telehealth. They're both available from 11 a.m. to 11 p.m. Next slide. Again, so once you get there, just have the 2 slides showing both ECMC and Kaleida. And you can just either request the next available visit or the actual next time slot that's available. And typically that's within 1 to 2 hours. So you'll just click on that, fill in this very simple form that just has some demographic information. There are information about insurance, but if you don't have it, you can proceed without insurance. And once you've completed that form, you just wait for one of our coordinators to contact you with a Zoom link. And then you can be speaking to a provider within an hour. Next slide. The other option then would be to just come through the Matters, come through the Matters platform in a traditional manner. So you could just click on submit a referral. Next slide. Once you complete the main slide, you can just, your main demographic, that's all right, you can skip right over that one. Once you complete that and register as you would with all of our Matters partners who are able to do that, they can just simply select telemedicine list rather than any of those brick and mortar ones that are the pins in red. So you can select the telemedicine list. Next slide. Again, I've just highlighted the two long-term partners that we do have that can initiate buprenorphine from the beginning all the way through to long-term care. That's REACH Project in Ithaca and Ophelia. You can just select a date from each one of those, and then they will contact you for their intake procedures as appropriate for each provider. Next slide. And that's it. Once you've completed that and you've selected your date, all of those blue arrows will be automatically initiated. So our referral partner will get all the information. The treatment partner will reach out within 24 hours. Each person will get access to the vouchers if they've selected them, and then they'll have those follow-up services as well from Matters. Next slide. A large part of what we also do here at Matters is our harm reduction program. So we are the sole supplier of the fentanyl and xylazine testing strips for our Oasis program that you may have seen, the advertising campaign. So you can simply click on that to order as many as 1,200 test strips for your organization. And now that we do have regional coordinators too, we can distribute naloxone regionally via trainings. Next slide. As many of you know, we have a harm reduction vending machine program too. Thanks to our partners in Alliance for Positive Health, we have one placed in Saranac Lake. And we have just recently extended that program. We've got another round of funding, so we're looking for anybody who's interested again. The harm reduction vending machine program has been such a successful program, just giving low barrier access to free supplies for those who may not be close to any of the other traditional brick and mortar clinics. So anybody who's interested, please just reach out. We are looking to partner. It's a free vending machine, and Matters will supply all of those supplies for a number of years. Next slide. So this is just a kind of brief roundup of the services that are offered with Matters. So those rapid referrals, no phone calls are waiting on hold. We do offer that transportation voucher to get you to and from your first clinic. We have that medication voucher that covers up to 14 days of that buprenorphine script. And then we've just recently added our 24-hour calls to effectively link that individual where the barriers continue, whether that's not getting your vouchers, not getting access, we're there to help you there as well. So we do hope that it decreases the amount of repeated visits in emergency rooms and gets people connected to long-term care. And that's it, I believe. We might have some FAQs that we can leave up, but that's pretty much it for Matters. So thank you for your attention and happy to answer any questions.
Thank you so much, Phil. And again, to Carrie, Brett, and Bianca as well. I don't see any questions in the chat right now. So again, to our participants, please, if you have anything you'd like to ask any of our presenters, you could feel free to put those in the chat, or you can unmute and ask directly right now. And we'll leave it open for the next few minutes. So a reminder, we will be sharing the slide deck and the recording, so you'll have access to all of our presenters' contact information and the slides as well.
I just want to thank you all for joining today and presenting on your programs. For the Alliance, I just wanted to ask quickly, I know that you had mentioned the referral, if you just call the number or email, is that referral sheet on your website at all either, or do we just get it by calling the Alliance?
If you could call the Alliance, our website is being updated right now, and it seems to be taking a long time, but in the future it will be on our website. But if you could just call that number or email the hub, we can send it out. or just call us and we can do the referral over the phone. Either way, just make that contact and we'll get it rolling quickly.
Okay, great. Thank you. I don't see any other questions in the chat box here. I know we're coming up right on time. We will be here until 2 o'clock if anyone has any questions. I don't see hands raised, I don't think. Someone had asked if you were able to get the Matters cards online. Phil?
I mean, the Matters card,
Yes.
I think the telemedicine, yes.
the telemedicine card.
Mhm.
I don't believe we have like a PDF online, but I'd be happy to send it to kind of anybody who is requested. We do have a PDF version of it. We do send it out to all of our partners. So I'd be happy to kind of send the PDF. And then if they wanted to send me some information, that I can work on getting some of those too.
Awesome. And Robert, the contact information for Phil will be in the slides that are sent out.
Yeah, and Donna has actually just been hired. So Donna, who's on the call here, is actually going to be the North Country Outreach Coordinator. Donna and I will be working very closely together to kind of increase our just presence and support for our partners in the region. And kind of just on that, the numbers so far this year have kind of really shown an increase in kind of involvement. We actually had in 2023, we had 2 referrals. And this year we've had 12 in the region so far. So it's a substantial increase. And just to point out the prevalence of telemedicine, 10 of those 12 have come through that telemedicine portal. So through that telemedicine card, getting in contact with our telemedicine providers and then being referred to AHI and some of our other partners on the call as well. So it's certainly a prevalent kind of form of connection in the region. So.
Phil, if you want to send the PDF of the telemedicine card over to me, I can include that with the follow-up materials along with the slides and the recording. Thank you.
That'd be great, Nancy. Yeah, thank you.
Any other questions for anyone?
Not a question, but if it's preferred, Nancy, I could also send a copy of our referral form to you as well, if that would be something that would be wanted.
Yeah, that would be great. We'll include that as well for our partners. Thank you so much.
Perfect. I will do that.
Great. Well, we are coming up right at 2 now. So again, thank you to all of our presenters and attendees for joining us this afternoon. If you do have any follow-up, feel free to send myself or Sabrina an email or any of our presenters, and we'll be happy to answer or connect you to any of our other partners that you may be interested in learning more from. And I hope that everyone has a wonderful rest of your day, and you'll see the email with the follow-up materials in the next couple of days. Thank you again to the Alliance and Matters again for joining us and presenting on your awesome work.
Thanks for the invite. Glad to be here. Thank you.
Thank you for having us. It's appreciated.
Thank you.
Thanks, everyone. Have a great one.